Hello everyone. Today I'm going to discuss about anatomy of the liver in detail. Here the competencies are to describe the liver under following headings, like we should know about its position, external features, relations, lobes, bare areas, ligaments, about Porta Hepatis, factors keeping the liver in position, its anatomical position, blood supply, nerve supply and lymphatic drainage. Liver is the largest internal organ and largest gland in human body. It, as such, the normal liver extends from fifth intercostal space in the right midclavicular line down to the costal margin. Weight is approximately 1600 grams in males, or you can say the range of 1600 to 1800 grams in males and 1200 grams to 1400 grams in females. At birth, it is approximately 150 grams. Location. As such, it occupies right hypochondrium, epigastrium, and frequently extends towards the left hypochondrium as far as to the left lateral line. This is normal location. I hope you understand all these quadrants. This is right hypochondrium, epigastrium, left hypochondrium, left lumbar region, left iliac region, hypogastric region, right iliac region, right lumbar region, and umbilical region. Whenever you are starting the naming of these 9 quadrants, you should start from one point, any one point, and go in a clockwise or anti-clockwise direction. So liver occupies right hypochondrium, epigastrium, and little part of the left lobe towards the left hypochondrium also, and small part into the right lumbar and umbilical region. Okay, major part is in the epigastrium and right hypochondriac region. Okay, some facts. As the body grows from infancy to adulthood, the liver rapidly increases in size, and this period of growth reaches a plateau around 18 years, and then again it is followed by gradual decrease in liver weight from the middle age. The ratio of liver to body weight decreases with the growth from infancy to adulthood. In infancy, it is about 1/18th of the body weight. In adulthood, it becomes 1/36th. Okay, and the liver weighs approximately about 5% of the body weight. Okay, in infancy, and it decreases to approximately 2% in adulthood. So infancy actually, according to the body proportion, it is bigger. Okay. So now coming to the size of liver. As such, it varies according to the age, sex, and body size. Shape as such, which means it according to the relations of the viscera nearby. Okay, which is you can say here this part will be in contact with diaphragm. Above it we will be having lungs, and in the middle part where there will be heart in the pericardium, and below here it is related to stomach and part of duodenum and kidney and suprarenal gland. So all these viscera which are in contact, they make produce some impressions, because of which it is wedge shaped. Factors which keeps the liver in position. The most important factor here is the hepatic veins. We have 3 hepatic veins: right hepatic vein, left hepatic vein, and middle hepatic vein, which are opening into the inferior vena cava. The most important factor which keeps the liver, the heavy liver, in position is hepatic veins. Second is intra-abdominal pressure by the anterior abdominal wall muscles and the nearby viscera. And third, but least important, would be the ligaments of the liver. Okay, like falciform, coronary, triangular ligaments, these ligaments. So these are all the functions of liver, like concentration of blood glucose, metabolism of fat, protein, some drugs, ammonia conversion, storage of all the vitamins, hematopoiesis in the fetus, and detoxification, and it is a part of mononuclear phagocytic system. Okay, so liver actually is a very important gland in our body. Presenting parts: surfaces, borders, it is like a wedge. Fine, wedge means when it is compressed by some nearby structures, so it is a wedge shaped. So it has number of surfaces, borders, lobes, and fissures, which we are going to discuss. So what are the surfaces here? It has you can say it has 5 surfaces. Superior, theoretically we can say it has superior, anterior, right lateral, posterior, and inferior or visceral surface. Okay, but the superior, anterior, and right lateral, they together are called as diaphragmatic surface because there is no any defined border, no definable border is there. So together they form diaphragmatic surface because of their relation with the diaphragm, right dome of diaphragm especially. And borders, if we say, we don't have so many, actually three borders are there, but the one border is very distinct called as inferior border. We'll discuss. So as such we can see surfaces, we can make out the parietal surface and visceral surface. Visceral surface is this one. This inferior surface is called as a visceral surface where all the viscera, nearby viscera are related. And parietal surface includes the superior surface, this is the anterior surface and right lateral surface, and behind will be the posterior surface. This is all parietal you can make out. In some books it is given as parietal and visceral. It is in some books it is given as superior, anterior, right lateral, posterior and inferior or visceral. Okay, so you can go according to your book. So here you can make out, this is superior view. So this pink area, this is superior surface. Okay, it extends towards the anterior also. This gray area is all anterior surface of liver. This is right lateral, so this is anterior view, this is superior view. So superior surface, anterior surface, right lateral, together they are called as diaphragmatic surface. And this is the posterior view. Posteriorly, this area, this brown area is all called as posterior surface. This pink area below this, if you turn the liver properly, you will find out this, the biggest area is called as visceral surface. Okay, coming to liver borders now. So theoretically we have three border, posto-inferior border and sharp inferior border. Okay, so posto-superior border actually ill-defined and separates this posterior surface from superior surface. Posto-inferior will be below the posterior surface, which will separate this posterior surface from inferior surface. So this is inferior surface, this whole is posterior surface. But again, these two borders are not well defined. The only definable border here is inferior border. So here we can make out this border. This is the border which is very sharp here. Okay. So this is your inferior border which separates this surface. Anterior and superior, or we call it and right lateral, together they are called as diaphragmatic surface, from inferior or visceral surface. Now this inferior border, as we can make out here, this border is related to anterior abdominal wall. This angle is called as infrasternal angle. This border is related with the anterior abdominal wall near the infrasternal angle. Okay, there will be anterior abdominal wall, and directly below this, within the margins of this angle, there will be anterior abdominal wall. And in the midline, it lies at the transpyloric plane. If we make an imaginary plane at the level of L1, which is called as transpyloric plane, about a hand's breadth below the xiphisternal joint. This is xiphisternal joint. If I take my own hand in my body only, so this my hand breadth will be corresponding to this. The lower margin, or you can say inferior border, corresponds to this point, hand's breadth below the xiphisternal joint. And if you make a plane here, this will pass through the transpyloric plane. Okay. For palpation, what you have to do, this is the only border which we can feel, because this border actually corresponds with the right costal margin. But in children and women, it may go below the right costal margin also. But usually in adult males, it corresponds to right costal margin. And here, if you have to feel this border, you have to go you have to feel with your right hand, and left hand should be behind in the loin of the patient. Okay, on the right loin behind, and right hand you have to start from the right iliac fossa and you have to go towards the right hypochondriac region till you feel something. Usually border is not palpable. This border also is not palpable until and unless it is enlarged. Okay, in some individuals it may be palpable normally also, especially in females. So in women and children, the border often projects a little below the right costal margin. The other two important features of this border, which you can make out here, one is here, one is here. So this is your notch, interlobar notch, and this another depression here where you can see the fundus of gallbladder. This is your gallbladder notch or cystic notch. So this is cystic notch and interlobar notch where we have presence of or attachment of falciform ligament. So these two are characteristic features here of the inferior border of liver. Now liver surfaces. As such, as I told you, superior, right lateral and anterior surface, they form the diaphragmatic surface. They are smooth and dome shaped, corresponds to the inferior surface of diaphragm, especially the right lobe, right dome of diaphragm. This come towards the left dome of diaphragm, middle part of the diaphragm actually, separated from diaphragm by this recess you all know, where we have the subphrenic recess. And from posterior organs, the retroperitoneal organs like kidney and suprarenal gland, by another recess behind, which is called as hepatorenal recess. Okay, it is covered by visceral peritoneum all over except few areas. The one major area in the back is the pear area. We'll discuss. Now superior surface, it is the largest surface. This view is actually from above. Okay, superior, this is right lobe, my right lobe, or you can say when you're looking at this picture, this is your liver. This is left, this is right. Here we have this falciform ligament. So this is superior surface. Okay, majority of this lies beneath the right dome of diaphragm, but small part here, this part, small part lies towards the left where there is a shallow depression here. This is for the cardiac impression. Okay, for because above this there will be central tendon of diaphragm over which there lies the diaphragmatic surface of the heart, covered with peritoneum except a small triangular area on the posterior surface called as the bare area. The left side of the superior surface lies beneath the left dome of diaphragm. So this is your superior surface. It is continuous with other surfaces. Okay. Anterior surface is triangular in cross section. This one is convex and is covered with peritoneum all over except for the attachment of this ligament, which is double fold of peritoneum, and reflection wherever there is a reflection of peritoneum, that is non-peritoneal structure. Okay, so fissure, there will be this attachment of the falciform ligament, that will be non-peritoneal. Most of this surface, anterior surface, lies in contact with the anterior attachment of diaphragm. Okay, now this anterior surface actually consists of broad right part, narrow left part, and intermediate triangular area. This is left part, broad right part, and intermediate triangular area. Now this right part, this part actually it lies beneath the right costal margin and is related with the diaphragm, 6th to 10th ribs of the right side, and lower margins of right lung and pleura. On the left side, this part will be related to diaphragm and left 7th and 8th left costal cartilages. So this part left, so we can divide the anterior surface into right part, left part, and intermediate part. Left part will be related to diaphragm, and outside diaphragm there will be 7th and 8th costal cartilages. Right part will be related to diaphragm, outside which there will be 6th to 10th, 6th, 7th, 8th, 9th, 10th, because it's bigger part. Okay, 6th to 10th ribs of the right side. Okay, now intermediate part, this part, it comes in contact with the xiphoid process slightly to the left of the falciform ligament and related with the anterior abdominal wall in the infrasternal angle, as I already mentioned. In the anterior surface, we a sickle shaped fold extending from the anterior surface of liver, connecting this with the diaphragm on one side and anterior abdominal wall on other side. It has attached margins and free margin. So this lower free border or free margin contains Ligamentum teres hepatis, a remnant of left umbilical vein, and this actually also contains paraumbilical veins, which connects ultimately the left branch of portal vein with the subcutaneous veins in the region of umbilicus. So that is a part of you can say portocaval anastomosis. But for now, you should remember this round ligament of liver or round ligament of liver. We have round ligament of uterus also in females, and ligamentum teres is one name for a ligament on the head of the femur also. So please don't get confused. It is Ligamentum teres hepatis. It is actually here. This is your falciform ligament. The lower free margin of the falciform ligament extending from this interlobar notch, it will go up to the umbilicus. This free margin contains remnant of obliterated left umbilical vein. In the fetal life, we have two umbilical veins, of which right disappears and left remains as such. So obliterated part of left umbilical vein, and it extends from umbilicus to the left branch of portal vein. This is called as your round ligament or ligamentum teres hepatis. This is anterosuperior surface. Now here we can see here, this is the one fissure here. In the fissure we have this Okay, this is fissure for Ligamentum teres hepatis. This peritoneal fold is entering inside this fissure. Okay, this is towards the left of your quadrate lobe. Now, after anterior surface, the right lateral surface is related to diaphragm in the mid-axillary line, and outside the diaphragm we have ribs. It extends from 7th to 11th ribs on the right side. But on relations, we can divide this right surface into upper one third, middle one third, and lower third. In upper one third, it is related to right lung and right pleural sac, because lung ends at the lower border of lung corresponds to 8th rib. So below 8th rib, we'll be having only pleura, which is forming right costodiaphragmatic recess. Okay, up to 10th rib, and below that it is related directly to the liver and to the diaphragm and thoracic wall. Okay, you can see here, this is your lung with the pleura. Here comes the pleura also, is not shown in the image. These are the ribs, costal cartilages, ribs, and the intercostal spaces. This is liver. Okay, this more grayish color, liver, and this brown is all diaphragm. So in the upper one third, it is related to lung and pleura. Middle one third, it will be related to only pleura and its recess, right costodiaphragmatic recess. Below, it will be related only to diaphragm, and costal margin will be costal margin, or you can say ribs, will be there in throughout extent. What is the importance here? Why you should understand these relations? Because sometimes when you have to take the biopsy of the liver, needle biopsy of the liver, it is to be done through right 9th or 10th intercostal space in the mid axillary line. We should not go in above 8th. Okay, because above 8th we have lung, we can injure the lung. Fine. Now coming to posterior surface, this is a bit complicated. You have to go from one area. Suppose we go from right towards left. So we have this area, the bare area of liver. Then we have this caudate lobe of liver. Then we have fissure for ligamentum venosum, and here we'll be having impression of abdominal part of esophagus, and then cardiac part of the stomach. This is your posterior surface, but there is no any well-defined demarcation between the posterior and superior surface and posterior and visceral surface. Usually we say posto-superior border, posto-inferior border, but they are ill-defined. We cannot make out exactly. Now the bare area, if you say, it's a non-peritoneal area covered by fibrous Glissen's capsule. It is related to, what are the relations here? It is a triangular area having apex on one side, base on one side. So base of the groove will be formed by, so you can see clearly in this picture, actually this is base. Base is formed by groove for inferior vena cava. Apex is opposite to the base. It is towards the right, which is formed by superior and inferior layer of coronary ligaments, ultimately forming right triangular ligament. So here will be right apex is formed by right triangular ligament. This is superior layer of coronary ligament or anterior coronary ligament. This is inferior or posterior coronary ligament. So above and below, it is related to, or upper and lower limits will be formed by anterior and posterior or superior and inferior coronary ligaments. Apex right triangular ligament, base is formed by groove for inferior vena cava. So this is your the bare area. Okay. This bare area contains branches of right inferior phrenic artery and some communications between portal and systemic diaphragmatic veins. So it is again a very important site of portocaval anastomosis. It is related to right suprarenal gland and sometimes anterior surface of right kidney, because right suprarenal gland is on the kidney. Fine, the lower part here, the right suprarenal gland. In this diagram, you can see clearly this is the bare area. Bare area is rough. There is non-peritoneal area. Okay, this is all glistening. This is all visceral, or you can say having visceral peritoneum. This is bare area. Groove for inferior vena cava. This is triangular ligaments, coronary ligament, right triangular ligament. Okay, the bare area. And below this here, this is your right suprarenal gland. So if you take out the liver, what is the image here is? Okay, if you take out the liver, you will find right suprarenal gland and part of right kidney in relation with the bare area. Other bare areas are also there. Sometimes MCQs are asked, all of the following are the bare areas of liver except. So in addition to the bare area, the groove for inferior vena cava, transverse fissure, porta hepatis, fissure for ligamentum venosum and ligamentum teres hepatis, and fossa for gallbladder. These are all the areas which are not covered by peritoneum. Groove for inferior vena cava, this fissure, fossa for gallbladder, and this transverse fissure. They are all, their floor is not covered by peritoneum. Fine. Sometimes what happens, band of tissue which bridges the groove for inferior vena cava and converts the groove into a tunnel. This is groove for inferior vena cava. Normally there is inferior vena cava. This is a groove. On one side is the caudate lobe. This is the bare area. Fine. So sometimes what happens is a band of tissue present, as we can see here. Sometimes like this, converting a groove into a tunnel. So then it is called as pons hepatis. There can be MCQ question on this. Fine. Now coming to ligamentum venosum, this fissure. Fine, this is inferior surface. This is part of the posterior surface. Actually, this is inferior visceral surface. This is fissure for ligamentum venosum. This fissure actually from here, peritoneum comes and it invaginates and comes out. Again from on the right side, a peritoneum layer comes and it invaginates and comes out. So in this fissure we have actually 4 layers of peritoneum. One peritoneum is going in and coming out, another peritoneum is going in and coming out. The one which is coming from here, which will be actually the peritoneum of greater sac. The one which is coming from this side will be the peritoneum of lesser sac. But the floor will be not having any peritoneum. That the floor will be containing a ligament, lodges a ligament called as ligamentum venosum, which is a remnant of ductus venosus of fetal life. So what actually is ductus? Actually a connection between the inferior vena cava here, inferior vena cava or hepatic veins on one side, to the left branch of portal vein, and shunting the blood of this umbilical vein in fetal life to directly to the hepatic vein or into the inferior vena cava. So in fetal life this is present. After birth it gets obliterated, and then in adults it will be called as ligamentum venosum. This is the visceral surface here, just in contact with the posterior surface. This surface is actually covered with peritoneum all over except the 3 sides. What are these 3 sides? One is fissure for ligamentum teres, this one. One is the fissure, transverse fissure in the middle part called as porta hepatis, and other this area, fossa for gallbladder. These 3 are other areas except the bare areas which are also not covered by peritoneum. Okay, so as such these 3 areas will not be covered by peritoneum. The important relations we'll be discussing, it starts from this side, from the esophageal impression on the posterior surface, and then we'll go from left to right side. Here you can make out, this is the lower end of esophagus. Okay, this is margin of liver. Okay, so this comes under posterior surface relation, and then we have this part of the stomach. Usually this if this is full, small part of the stomach will come, otherwise if it is empty, and to superior surface of the stomach comes in contact with the gastric area. After that, this is your lesser curvature on which there will be attachment of lesser omentum. So this area will be related to lesser omentum. Here is your pyloric part of the stomach. Then we have duodenum, first part, second part. This is your transverse colon, part of transverse colon continuing as the descending colon. So this is hepatic flexure of colon. This is your right suprarenal gland resting on the kidney. And this is the bare area. You can see this margin is the bare area. So these are actually the relations of the visceral surface of liver. Okay, just to revise again, the gastric impression will be there. Now here along this lesser curvature, there will be one elevation called as omental tuberosity, which actually corresponds to tuberosity on the pancreas. Okay, so this is your omental tuberosity, your here, which will corresponds to this in this area, not very clear in this image. Then we have fissure for ligamentum venosum. This is fissure for ligamentum teres hepatis. This area is your quadrate lobe, which is bounded on one side, on left side by fissure for ligamentum teres hepatis, on right side gallbladder fossa. Above there is porta hepatis, and below there is free margin of your inferior border. Okay. Now in this caudate lobe, there is one process. This process will be called as papillary process, and this extension is called as caudate process. So this caudate lobe gives one extension, below which lies your epiploic foramina. So this caudate process forms upper boundary of epiploic foramina. Just below this area will be related to duodenum. Duodenal impression will be there. First part will be continuing as second part. This is your colic impression for right colic flexure or hepatic colic Hepatic flexure of colon. This is your anterior surface of right kidney, and over this lower part of bare area, we'll be having right suprarenal gland. This is how I told. This is esophageal impression. This is gastric impression. Here will be lesser omentum and tuber omental, we call it. This is caudate lobe, caudate process. Here will be papillary process. Fissure for ligamentum venosum. This is your porta hepatis, quadrate lobe, caudate lobe. This is duodenal area. There will be pyloric part of the stomach. This is gallbladder fossa. This is colic area, renal, and here will be right suprarenal gland. These type of diagrams you can use in your exams also. So liver, this one, this is a fissure here. What are the structures passing through? It is like a porta. Porta means it is giving entrance to some structures, and some structures are coming out. So we have right and left hepatic ducts, right and left branches of hepatic artery, and right and left branches of portal vein. The most posterior, the blue color thing you can see, is the portal vein. In front of it and towards the right, we'll be having right anterior, you can say, is hepatic artery branches, and left anterior will be your common hepatic duct, or the division of right ducts like right and left hepatic ducts. Few lymphatics, they will be coming out, okay, and few hepatic lymph nodes may be there, which drain the liver and gallbladder and send their efferent vessels to the celiac lymph nodes. It also transmits sympathetic nerves, which provide afferent pain impulses from the liver and gallbladder to the brain. And the fibers, actually, they are coming from T7 to T9 mostly, so referred pain will be there in the inflammation of these viscera to the lower pole of, or you can say, right inferior angle of right scapula. Okay, it also gives passage for hepatic branch of vagus nerve. Now coming to the lobes of the liver. So we can divide the liver actually anatomically and physiologically, or surgical division also you can say. So how they are using this clinical anatomy, clinical divisions during surgery. Okay, so somewhat in anatomy we read differently than what they are doing the divisions in surgical branches. Okay, so anatomical lobes. Actually, anatomically we divide the liver into two lobes, one big, that is right, one small. Lobes are there, separated by falciform ligament in front or anteriorly and above, you can say in front and above by attachment of falciform ligament. I'll show you. Posteriorly and inferiorly we have two fissures, fissure for ligamentum venosum and teres. And in addition to these ligament, this is a continuous line actually dividing the lobe into right and left. But with these we have two extra lobes, accessory lobes we call it, as you know, caudate and quadrate, already we are done with, and one more extra sometimes present as Riedel's lobe. So in this image we can see this is an anterior view where you can see this diaphragmatic surface, anterior surface, right lateral, and superior surface. Okay, so this is the attachment of falciform ligament. So anteriorly and above, that means in between diaphragm and anterior abdominal wall there is a ligament which is actually double fold of visceral peritoneum called as falciform ligament. It is going towards the right and left, forming the here it will be forming superior and inferior layer of coronary ligaments. Towards the left side it will be forming triangular ligament, left triangular ligament. On the right side, superior and inferior. You can see here this is superior and inferior layer of coronary ligament, and then it will be forming right triangular ligament. Towards the left directly it forms left triangular ligament extending up to diaphragm. Okay, so this is anterior view. In the anterior, so I told you anatomically we divide the liver by falciform ligament or fissure for falciform ligament on the anterior surface, anteriorly and above, as you turn the liver. So this is how it is in anatomical position. If I turn the liver, I can see here this is right and this is left. So here we have fissure for ligamentum venosum and fissure for ligamentum teres hepatis. This is a continuous fissure here. In between, in the middle part we have this porta hepatis, fissure for porta hepatis. So this fissure is continuous with the falciform ligament anteriorly. So it is anatomically dividing the liver into left smaller lobe and big right lobe. Okay, so fifth-sixth of the liver is formed by right lobe and 1/6 by the left lobe. This is left, this is right. This is visceral surface you can see, and posterior surface. So coming to caudate lobe surface, this one. Here it is bounded on one side, on left side by fissure for Ligamentum Venosum, on right side by groove for inferior vena cava, and below and in front by Porta Hepatis. On the other hand, this is your quadrate lobe, okay, which is bounded on left side by fissure for Ligamentum Hepatis, on right side by gallbladder fossa, above by Porta Hepatis, and below and inferiorly by sharp inferior border. Now in the caudate process, we have a caudate lobe, we have an extension here. This is called as caudate process, which becomes continuous with the right lobe of liver, and this forms the superior boundary of epiploic foramina. On other side, on the right side, there's another elevation. We can say it is a papillary process. This actually represents the point where there is origin of celiac trunk from abdominal aorta. This area, this elevation comes in contact with celiac trunk. So we can make out now this is your caudate lobe with the two processes, papillary process and caudate process. So anatomically it is also a lobe, but it is a part of right lobe. Similarly, quadrate lobe also, it is a part of right lobe of liver. So this is your quadrate lobe. Anteriorly or inferiorly, it is bounded by inferior border, posteriorly by porta hepatis, to the right fossa for gallbladder, and to the left fissure for ligamentum teres. This part will be related to pyloric part of the stomach. Another lobe, sometimes extension, a tongue-like extension beyond the right costal margin, you may find in some liver. The etiology has been proposed to be either congenital or acquired. Its misidentification as a pathological abdominal mass has led to surgery actually. Pathology can also occur within it because of malignancy or even torsion, and it can cause some atypical hepatic symptoms sometimes when it is low in the pelvis. Okay, this is just, you can remember here, it is an extension of the liver beyond the right costal margin. Usually this inferior border extension beyond the right costal margin. Tongue-like extension, Riedel's lobe. For many years, the segmental anatomy of the liver was of little importance. However, since the development of liver resection surgery, the size, shape, and segmental anatomy of the liver have become clinically important, especially with regard to liver resection for metastatic disease. Indeed, with detailed knowledge of the segments, curative surgery can be performed in patients with tumor metastasis. So the liver is divided by a principal plane which divides the liver into approximately two halves of almost equal size, as cholecystovena cava line or Cantel's line. In front, it extends from gallbladder fossa, middle of the gallbladder fossa, to the middle of inferior vena cava. It lies actually to the right of attachment of falciform ligament. So anatomically, we have right liver lobe is larger, left liver lobe is very small, whereas physiologically the two lobes are almost of equal size. The same line, if you go towards the back or in the inferior surface, we can see this line extends from middle of the gallbladder fossa and it passes through the middle of caudate lobe. So physiologically, gallbladder fossa, this quadrate lobe, and half of or major part of caudate lobe are the parts of left lobe, whereas anatomically we have seen both quadrate and caudate lobes are the part of right lobe. Now this line, through this line we have actually the presence of middle hepatic vein which drains into inferior vena cava. It lies in this plane. They are again divided into small segments by Couinaud in 1957 based upon the distribution of bile ducts and hepatic vessels in the parenchyma. The 8-segment anatomy of the liver is actually important because these segments are functionally independent segments. They have its own vascular inflow, outflow, and biliary drainage. So how these segments are divided? Here we have some sectors or fissures, you can say, called as portal fissures, where the main portal fissure is occupied by this middle hepatic vein which lies in the Cantel's line or cholecystovena cava line, dividing the segments into right and, or you can say, lobe into right and left part. Then we have right portal fissure occupied by right hepatic vein, this one, right hepatic vein, dividing the right lobe into anterior and posterior segments. And we have left hepatic vein, which divides the left lobe into medial and lateral segments. And here we can see this is a portal vein which divides or separates the upper and lower segments of the liver. Now here for each segment we have one branch of portal vein, hepatic artery and bile duct. The peripheral part of each segment has a vascular outflow through the hepatic veins. Now Couinaud has given 8 segments. So first segment is actually the caudate lobe. And after that we have to go in clockwise fashion. So 1, 2, 3, 4 will be in the left lobe. 5, 6, 7, 8 are in the right lobe, and each of these segments can be resected without damaging the hepatic veins. Okay, so the features are extremely consistent between the individuals. If we know which one is a first lobe, we can then count it and we can make out exactly the which lobe we have to resect. For example, from a surgical perspective, a right hepatectomy would involve division of liver in the principal plane, in which segments 5, 6, 7, 8 would be removed, leaving segments 1, 2, 3, 4. Coming to peritoneal deflections or ligaments, you have heard about. We have falciform ligament, already I described about it. It's like falciform ligament is like sickle shaped fold. Now continuation of this on the right side and left side. The same layer, peritoneal layer, double fold of peritoneum, is named differently. If you go towards the right side, it will be called as coronary ligament. Superior and inferior coronary ligament together they will be forming right triangular ligament, which will be connecting the right lateral surface of liver with the diaphragm. Similarly, on the left side, there will be no coronary ligaments, but there will be left triangular ligament. On the left side, there will be anterior and posterior layers which are forming triangular ligament. And these are false ligaments. Actually, the ligaments are called as false and true. False ligaments are those which are actually the peritoneal folds. Okay, so we have falciform ligament, coronary ligaments, right triangular, left triangular ligament, and lesser omentum, which is already done in the previous class. Okay, so I'm not dealing in detail. So these are all the peritoneal reflections of false ligaments of the liver, which are accessory things in holding the liver. Okay, so in this diagram we can see this is the posterior surface. Here you can see the same falciform ligament. From here it is going like this is like a crown. Okay, so inferior layer or superior layer, coronary ligament, superior lamina and inferior lamina, or anterior and posterior layers of coronary ligament, both are correct. Together they are meeting here and they will be called as right triangular ligament. It will extend up to the diaphragm. Right triangular ligament. On the left side, it will be having anterior and posterior layer of left triangular ligament. These are all continuations of the falciform ligament. Okay, so these are all the peritoneal folds. Called as lesser omentum, which extends from lesser curvature of the stomach on one side and upper part of first part of duodenum, and it is going up to the fissure present on the inferior surface of the liver. It is actually occupying the inverted L-shaped location, the part which is extending from liver up to the lesser curvature of the stomach. This is called as hepatogastric ligament, hepatogastric part of the lesser omentum. And the other one which is extending from liver to the duodenum, that will be called as the hepatoduodenal portion. The contents are the one which are forming the right free margin of lesser omentum, where we have portal vein in the posterior part and hepatic artery and division of bile duct. So they are forming the important boundary, anterior boundary of foramen of Winslow. Now coming to true ligaments, this already I discussed. So true ligaments includes a ligament which are present since birth from the fetal life. We have ligamentum teres hepatis and ligamentum venosum. Okay. Vascular supply. The vessels connected with the liver are actually the portal vein, hepatic artery and hepatic veins. Portal vein and hepatic artery ascend in the lesser omentum, you all know, into the porta hepatis, where each bifurcates. Hepatic bile duct and lymphatic vessels, they descend from the porta hepatis in the same momentum, they come out. Okay, right? Portal vein enters, artery enters, and duct comes out. Hepatic veins, they are connected by with the inferior vena cava. From the inferior vena cava, they are connecting the liver, right? So hepatic veins leaves the liver via its posterior surface and run directly into inferior vena cava. Okay, they drain the blood directly into the inferior vena cava. So blood supply or vascular supply of actually the blood to the liver enters via this portal vein and hepatic artery. Hepatic artery as such is a branch of celiac trunk which divides into right and left terminal branches when it enters the porta hepatis. It is responsible for providing 25% of the blood to the liver. Major portion of blood enters by the portal vein. 75% enters the portal vein. And after circulation through the liver, the blood comes out through these hepatic veins into the inferior vena cava. Here is a line diagram. We can see here hepatic artery carries oxygenated blood, oxygen rich blood. Hepatic portal vein carries nutrient rich blood but oxygen poor blood to the liver. And after that the blood goes out through the hepatic veins into the inferior vena cava and then into the heart, and bile comes out through the hepatic ducts. This is the line diagram which you can use for the exams also. Coming from the portal vein, this is portal vein, this is hepatic artery. So from portal vein and hepatic artery, blood is entering here. So the blood coming from portal vein, they are rich in products of digestion which have been absorbed from gastrointestinal tract, and this is the arterial blood, oxygenated blood. Both of these they mix here, and this together is conducted to the central vein of each liver lobule by the liver sinusoids. So they are coming here, these are liver sinusoids, and ultimately it is reaching into the central vein. The central venous blood, now this blood will be carried here. We can see these are the central vein. So now the central venous blood will be carried or will be draining into the right and left hepatic veins, and these leave the posterior surface of liver and open directly into inferior vena cava. So ultimately central veins, they are going into hepatic veins into inferior vena cava. So liver as such produces large amount of lymph, about 1/3 to 1/2 of all body lymph, and it has the lymph here as abundant protein content. The drainage from liver actually may pass to, or the efferent vessels you can say, above and below the diaphragm. So we divide the lymphatics into superficial and deep. So the superficial is of the liver and drains into 4 directions. One is here, the one which drains the posterior surface, caudate lobe, and posterior part of the inferior surface of right lobe. Okay, it goes to this pericaval lymph nodes or inferior vena cava nodes. Most of the surface from the majority you can say of the inferior surface and anterior surface and most of the superior surface, they drain into the lymph nodes in the porta hepatis called as hepatic lymph nodes. And from the posterior surface of left lobe here, this part will go to nearby pericardiac lymph nodes. Okay, so this is how we have 3 groups you can say. Ultimately the subserosal areolar tissue is draining into vena cava lymph nodes, hepatic lymph nodes, and pericardiac lymph nodes. So majority of the parenchyma. So we divide the deep lymphatics into ascending trunk and descending trunk. For upper part of the parenchyma or upper part of the liver parenchyma, they accompany the hepatic veins and pass through the vena cava opening and ultimately draining into vena cava lymph nodes. Lower part of the parenchyma will emerge from the porta hepatis and drain into hepatic nodes. Nerve supply of liver. It is carrying parasympathetic and sympathetic fibers. Parasympathetic and sympathetic is by greater splanchnic nerves carrying fibers from T6 to T9 segments of the spinal cord. They form celiac plexus around the celiac trunk. So both sympathetic and parasympathetic, and pain fibers will be traveling to these segments. So those areas having same dermatome innervation, they will be causing referred pain. So how you palpate the liver? Here you have to keep, it is called as, this area is called as loin or your lumbar region. Right hand you have to keep in front of the anterior abdominal wall, especially you have to start from right iliac fossa for palpation of liver. So start palpating from the iliac fossa and you have to ask the patient to take deep breath. Okay, and usually you have to reach up to the right costal margin, and because the inferior border of the liver corresponds with the right costal margin, you may not be able to feel separately unless it is enlarged. But if you are able to feel, then you have to feel whether the costal margin, how much it is below the costal margin, the inferior border. What is the consistency of the liver, when it is smooth or irregular, or it is hard, soft, and pain is there or not. We call it tenderness. Patient is able to say that, oh, you are touching, it is painful, so tenderness. And whether it is pulsatile, the swelling or any enlargement is pulsatile or not. Usually in tricuspid regurgitation, they say we have pulsatile, enlarged liver can be seen. So you can feel pulsation with your right hand. Okay. Hepatitis, it is inflammation of the liver. Most commonly, it is caused by C, D, and E. These are the viral infections. Then other causes are toxic substances like alcohol or some drugs, and some autoimmune disorders may also cause hepatitis. These infections can also lead to prolonged inflammation, can lead to uh, fibrosis of the cells and parenchyma, replacing the liver into fibrous tissue and leading to its shrinkage, commonly by infection, as I mentioned earlier, and toxins, alcohol, and poisons. These can lead to cirrhosis, liver cirrhosis. 28th July is celebrated as World Hepatitis Day, so that to spread the awareness among the population about the hepatitis and different measures which can be taken to prevent this disease. Liver biopsy. It is a common diagnostic procedure with the patient holding his or her breath in full expiration to reduce the size of costodiaphragmatic recess and the likelihood of damage to the lung. A needle is inserted through the right 8th or 9th intercostal space in the mid-axillary line. The needle passes through the diaphragm into the liver, and a small specimen of liver tissue is removed for microscopic examination. So this is all about liver. Please open your book and read it again and revise the things, okay? Thank you.